Okay, today I'm going to be talking about the management of cryptococcal meningitis. And I thought I'd start by just outlining some of the recent epidemiology about this particular fungal infection in HIV. There are nearly 1 million cases of cryptococcal meningitis diagnosed each year globally, and more than 600,000 deaths. That's a fact that many of us don't realize anymore in the HIV world because of the advent of very successful antiretroviral therapy, but in resource-limited settings around the globe, there's still an appreciable rate of cryptococcal meningitis. And it currently accounts for anywhere from 13 to 44% of deaths in HIV-infected persons in resource-limited settings. The incidence of cryptococcal meningitis has declined with access to effective antiretroviral therapy, although it still has an unacceptably high mortality rate in resource-limited settings, anywhere from 35 to 65% mortality, as compared to only about a 10 to 20% mortality in developed countries. The increased mortality rate in resource-limited settings is consequence of the delays in diagnosis of cryptococcal disease, poor availability, and the high cost of amphotericin B, which is one of the cornerstones of antifungal therapy for this infection. Cryptococcal meningitis generally occurs in patients with very low CD4 cell counts, usually in the range less than 100 CD4 cells per microliter. Although most of the work looking at the risk of cryptococcal meningitis was done in the pre-ARV era, or effective ARV era. So we don't really know what the other risk factors might be in people who are on antiretroviral therapy. So I thought it might be illustrative to go through a case presentation because several of the points I'm going to make about management have to do with how individuals with cryptococcal meningitis present. So this case was one we saw in our setting several years ago now, but this was a 34-year-old white woman who came into our clinic on HIV with a previous diagnosis of HIV and AIDS, and she was on her first antiretroviral regimen with a fixed-dose combination of efavirenz, tenofovir, and emtricitabine. She'd been on that therapy for 2 years and now had evidence of failing antiretroviral therapy with an increased viral load of 118,000 copies, so clearly a very high viral load. Her CD4 cell count was 28 at the time we first saw her, and her main complaint was new onset of headache, fever, somnolence. We got a serum cryptococcal antigen that was very high at a titer of 1 to 1,024, and did a lumbar puncture on her at the time. She had 52 white blood cells, 86% of those were lymphocytes. Her protein was only mildly elevated at 58, her glucose was mildly decreased at 43, and her cerebrospinal fluid cryptococcal antigen was also quite elevated at 1 to 4,096. She had no focal deficits on physical examination, and other than the headache and fever, no other major physical findings. She was started on intravenous amphotericin B in combination with 5-flucytosine and was treated for 14 days, then switched to consolidation therapy with fluconazole in a dose of 400 milligrams per day. Her clinical symptoms improved. We did a follow-up lumbar puncture, and cerebrospinal fluid showed no white cells. Her cryptococcal antigen in the CSF had come down quite appreciably to a titer of 1 to 64, and her CSF cultures were now negative. In the interim, during her treatment for cryptococcal meningitis, we also got genotypic resistance testing for her HIV and identified an M184V mutation and a K103 mutation, suggesting that she had resistance both to her efavirenz and her 3TC. So she was subsequently switched to a second-line regimen for treatment of for her antiretroviral therapy to darunavir boosted with ritonavir, and she had a 3-drug NRTI combination of tenofovir with lamivudine and zidovudine. So that's a fairly typical clinical presentation of cryptococcal meningitis. Usually the presentation in patients with early cryptococcal meningitis is a subacute meningitis, meaning that patients develop symptoms relatively slowly over time, but they may also present with an acute meningoencephalitis syndrome with obtundation and coma in more advanced stages. The first symptoms are usually a fever and headache. It's usually uncommon to have neck stiffness. You can see classic meningeal symptoms with neck stiffness and photophobia, although that generally occurs in people with more severe disease and is really only seen in the presentation of cryptococcal meningitis about a quarter to a third of the time. You can see more severe encephalopathy syndromes with altered mentation, obtundation, focal neurologic deficits, and seizures, and this is usually a consequence of increased intracranial pressure or direct yeast infection or cryptococcal infection of the brain. This is usually seen as the disease progresses without adequate therapy. Rarely we can see disseminated cryptococcal disease, disseminated outside of the central nervous system, and in this case it can involve any organ system. Skin lesions are occasionally seen, and these are relatively nonspecific in appearance. They may be umbilicated, meaning they have a central umbilication in the raised skin lesion, but usually are maculopapular. Occasionally they can be pustular, and they may look like molluscum contagiosum, another common viral infection of the skin seen in people with advanced HIV disease. We can also see pulmonary infection with cryptococcal disease. That patients will often, in that instance, complain of cough, dyspnea, usually with an abnormal chest x-ray. And although you can see a chest x-ray findings that might mimic pneumocystis pneumonia, typically cryptococcal disease in the lung is associated with lobar consolidation isolated to one lobe or more of the lung, with occasionally nodular infiltrates. The diagnosis of cryptococcal meningitis is based on identifying organisms or cryptococcal antigen in the cerebrospinal fluid. And generally, you'll see a cerebrospinal fluid pattern with mild elevation of serum protein, low to normal glucose concentrations, and often a lymphocytic pleocytosis. Some HIV-infected individuals will have very few CSF inflammatory cells, but usually we'll see on an India ink stain or a Gram stain evidence of yeast forms in the spinal fluid. It's very important when you're doing a lumbar puncture to obtain a CSF opening pressure. This is often elevated, and pressures higher than 25 centimeters of water is quite common. It's the high intracranial pressures that are associated with many of the complications of cryptococcal meningitis, and it's also important to know that opening pressure when you're thinking about management, because you need to manage the increased intracranial pressure along with the management of the infectious process in order to have a successful outcome. This is a depiction of an India ink smear of stain of the cerebrospinal fluid, and usually what we'll see in an India ink stain are these round yeast forms that have almost a halo appearance around them, and this is due to capsular polysaccharide that surrounds the yeast forms. This one is a very classic appearance because not only do you see the primary yeast, but you also see a little budding yeast off of these organisms that is representative of replication of the Cryptococcus in the spinal fluid. India ink doesn't penetrate this capsular polysaccharide, which is why it has this clear halo around the yeast forms. If you do a Gram stain or other types, this one happens to be a Giemsa stain, you'll see this background of a polymorphonuclear leukocyte that has ingested these yeasts, and you just see this dark black staining yeast form, in this case without being able to demonstrate the capsular polysaccharide, because that is obscured by the Giemsa stain. So demonstration of organisms in the spinal fluid is the classic gold standard test for cryptococcal disease, and this can be demonstrated either through these stains or through cultures. Usually cryptococcal antigen, which is antibody to, or which measures cryptococcal polysaccharide antigen itself, is present in the CSF in high titer. And if you recall the case presentation, the CSF titer in this case was 1 to 4,064, and that's quite a high titer. You will often see cryptococcal antigen present in the serum as well. In HIV-infected individuals, blood cultures may be positive in half of the patients, and the CSF cultures are usually positive in about 95% of individuals. You'll grow the yeast in anywhere from 5 to 7 days in culture, and as I've already talked about, India ink or gram stain can give you a rapid diagnosis in addition to the cryptococcal antigen. There are a number of point-of-care diagnostic tests now available for rapid diagnosis of cryptococcal disease. In addition to cryptococcal antigen, we can also use a dipstick lateral flow assay. This tests antibody to a particular antigen that's found in the polysaccharide capsule of the organism. This lateral flow assay is 98% sensitive in patients who have had active or recent cryptococcal disease and correlates strongly with the ELISA and the cryptococcal antigen test. So if you're at point of care and don't have access to a cryptococcal antigen, you can do this dipstick lateral flow assay on serum or urine. There is another lateral flow assay that tests using monoclonal antibodies that tests capsular polysaccharide antigen that covers all 4 of the main cryptococcal serotypes. So this one has 100% sensitivity when compared to blood culture. So both of these lateral flow assays are point-of-care diagnostic tests that are very sensitive and can provide a rapid diagnosis for cryptococcal disease if you have availability of these but aren't near a central lab that can do some of the other testing. So obviously, once you identify someone with cryptococcal meningitis, the rapidity with which you initiate effective therapy for the fungal infection makes a big difference in overall prognosis. The preferred induction therapy for cryptococcal meningitis is the use of amphotericin B in combination with flucytosine. In developed countries, we have access to a liposomal form of amphotericin B, and this provides an ability to lower some of the rates of toxicities associated with amphotericin. But it has similar efficacy to the standard or conventional formulation of amphotericin B deoxycholate, but lower rates of nephrotoxicity. So if you have access to the liposomal amphotericin, it's preferable to use that particular formulation to reduce some of the toxicity on the kidney that's often seen with standard amphotericin. Flucytosine is given orally in a dose of 25 milligrams per kilogram 4 times a day. We usually use that in combination with amphotericin during the first 2 weeks of therapy, which is the induction phase. There are a number of alternatives that can be used if you don't have access to amphotericin or flucytosine, and those include some of the azole therapies that I'll go over in a minute. But the addition of flucytosine to amphotericin B has been shown in clinical trials to be critical to acute management of cryptococcal meningitis. It results in more rapid sterilization of the cerebrospinal fluid, and in several randomized clinical trials has been shown to reduce the overall mortality rate associated with cryptococcal meningitis. As I talked about earlier in the epidemiology of cryptococcal disease, one of the principal differences in management between developed countries and resource-limited settings is that most resource-constrained settings don't have access to flucytosine, and that has made a big difference in terms of mortality rates associated with cryptococcal meningitis. So if you can get access to flucytosine, it's a key component to the induction phase of therapy. If you don't have access to flucytosine, it's very common that experts will recommend the use of amphotericin B in combination with high-dose fluconazole. Fluconazole in high doses is thought to confer similar benefit to flucytosine, although this hasn't been tested in very large randomized clinical trials. But the synergistic activity of the azole therapy with amphotericin B is associated with improved mortality when compared to amphotericin B alone. If you don't have access to amphotericin B, high doses of fluconazole can be used, and it's recommended that it be used in combination with flucytosine, but understanding that areas that don't have access to flucytosine may need to use even higher doses of fluconazole. And one of the alternative therapies in resource-limited settings is that if you can't use amphotericin B, you should be giving very high doses of fluconazole in the range of 1,200 to even 1,600 milligrams per day. There are a number of ancillary support issues that occur in patients with cryptococcal meningitis. It's been recognized in clinical trials that up to 93% of very early death due to cryptococcal meningitis, and by early I mean within the first 2 weeks of therapy, and about 40% of late deaths are a consequence of increased intracranial pressure. Therefore, it's been demonstrated in clinical trials that obtaining an opening pressure to evaluate the presence of increased intracranial pressure and then management of that increased intracranial pressure also makes a difference in early and late mortality. And some of the ancillary activities to support the management of increased intracranial pressure include treating patients with serial lumbar punctures, removal of 20 to 30 milliliters of cerebrospinal fluid daily may be enough to reduce the pressure, the cerebrospinal fluid pressure by about 50%. And this is often recommended to be done daily until you see both improvement in the increased intracranial pressure and clinical improvement in the patient. If serial lumbar punctures can't be done, or if they're not effective, having a neurosurgical consultation for CSF shunting may be the next step. A lumbar drain or a ventriculostomy may be necessary and is recommended if you can't do serial lumbar punctures or if you have persistence in the signs and symptoms of increased intracranial pressure after serial lumbar punctures. Corticosteroids and mannitol are some other supportive therapies that reduce inflammation and reduce intracranial pressure in some other settings, but they've actually been found to be ineffective in the management of increased intracranial pressure in the context of cryptococcal meningitis. So it's not generally recommended that we use either of these therapies. And one particular complication of corticosteroid therapy is that it impairs peripheral or polymorphonuclear leukocyte function and impairs glucose metabolism, so that it actually complicates the therapy of cryptococcal meningitis. Acetazolamide is another drug that's often used for increased intracranial pressure management in other settings, particularly in post-neurosurgical settings, but this has actually been shown in clinical trials to increase mortality due to the electrolyte and fluid shifts that are induced by acetazolamide, and therefore it's not recommended in individuals with HIV-associated cryptococcal meningitis. Post-treatment, once you get patients through that first 2 weeks of induction therapy, it's sometimes recommended that a repeat lumbar puncture be performed at the end of 2 weeks in order to ensure that you've cleared organisms from the cerebrospinal fluid. Individuals who have persistently positive CSF cultures after 2 weeks of therapy, often that's associated with less favorable outcome and is predictive of future relapse. So it's often a good test to do for post-treatment monitoring if you want to make sure that your patient is adequately responding to antifungal therapy. This is just a clinical trial that illustrates that point. It was a prospective longitudinal cohort study that was performed in South Africa in a population of HIV-infected patients with cryptococcal meningitis. Individuals in this study had been treated with induction therapy with amphotericin B alone and then had been started on antiretroviral therapy. And they evaluated 106 patients and demonstrated at the end of 2 weeks of amphotericin B alone that about 51% to 52% were persistently CSF culture positive. When they compared this group of individuals who had persistently positive cultures with the group who had sterilized their CSF, they found that those who had cleared the CSF had fewer neurologic complications, fewer episodes of relapse, and reduced mortality. So I think, again, illustrating the point that you want to have rapid clearance of organisms from the cerebrospinal fluid to have the best chance for a successful outcome. Following the induction period of treatment for cryptococcal meningitis, we embark on what's referred to as the consolidation phase of therapy, and this is generally a step down in treatment from the intravenous amphotericin and flucytosine to a consolidation phase for 8 weeks with oral fluconazole. The consolidation therapy should be started after at least 2 weeks of induction phase treatment, but only if clinical symptoms have clearly improved and if repeat CSF cultures are negative. Then patients can be switched to fluconazole in a dose of 400 milligrams daily, or alternatively another one of the azole drugs, itraconazole, is sometimes used as well. Once patients have completed this 8 weeks of what's referred to as consolidation therapy, they move on to what's termed maintenance therapy or secondary prevention therapy for preventing relapse or recurrence of cryptococcal meningitis. And this really just refers to a further step down in the intensity of treatment to a dose of fluconazole of 200 milligrams a day. And this is generally continued for at least a year. You can stop maintenance therapy with fluconazole once an individual has become asymptomatic, has completed a year of therapy, and has been started on antiretroviral treatment and has had a good CD4 cell count and viral load response to antiretroviral therapy. So just going back to the case presentation, I want to highlight a couple of other issues related to cryptococcal meningitis in the post-treatment period. In this case, our patient came back after a good clinical response, now on consolidation treatment, and 1 month later complained of fevers, headache, nausea, neck stiffness, and malaise. And despite the fact that she had what appeared to be a recurrent meningitis syndrome, her CD4 count had risen dramatically. Her viral load was undetectable with less than 50 copies per ml using an ultrasensitive assay. And we did a repeat lumbar puncture, and her cerebrospinal fluid had 10 white blood cells, a normal glucose, a normal protein. She still had some persistently positive cryptococcal antigen, but cultures were negative. Her MRI showed enhanced leptomeninges, and this is a picture of a brain MRI, magnetic resonance image of her brain. And what we mean by enhanced leptomeninges is this meningeal lining around the brain showed increased uptake or brightness on the MRI scan, suggesting that there was an inflammatory reaction here surrounding the meninges. And what we ultimately diagnosed in this patient, based on negative cultures from the cerebrospinal fluid and the relatively benign CSF parameters, was evidence for cryptococcal-associated iris, or immune reconstitution inflammatory syndrome. And this is a syndrome that occurs when starting antiretroviral therapy in the presence of an acute opportunistic infection, in this case, cryptococcal meningitis. Iris is seen after initiation of antiretroviral therapy in about a third of HIV-infected individuals who have recovered from cryptococcal meningitis. Patients who are at increased risk for this inflammatory reaction if they are antiretroviral treatment naive, although in this patient she was not treatment naive, but we had made a switch to a new regimen in her. patients who have high viral loads or HIV RNA levels, and in the case of our patient, she had a viral load of greater than 100,000 copies, and individuals who have lower levels of CSF inflammation on initial presentation. That was not the case with our patient, but she did have these several other risk factors for cryptococcal iris. So this was an example of a presentation of cryptococcal iris in a patient recovering from acute cryptococcal meningitis. The situation referred to often as paradoxical cryptococcal iris occurs in the instance of someone with a prior diagnosis of cryptococcal disease, on initial clinical response to antifungal therapy, on antiretroviral therapy, and is really just another manifestation of iris. And it usually is seen within 12 months of starting or switching antiretroviral therapy. Clinical disease demonstrates worsening of the inflammatory manifestations of cryptococcal disease, but otherwise no documentation of the presence of fungi in the cerebrospinal fluid or blood. And so in order to meet clinical criteria for cryptococcal iris, you need to exclude other causes of clinical deterioration, such as non-adherence to antiretroviral or antifungal therapy, failure of antifungal therapy, or failure of your antiretroviral treatment. So the management of cryptococcal iris and the management of treatment failure can often be complicated in the setting such as this patient's presentation. More often, what we see in treatment failure is inadequate induction therapy, meaning patients had not had access to combination induction therapy, or maybe a consequence of drug interactions that reduce the drug levels in the presence of treatment, or the development of iris. And so when patients have recrudescence of their symptoms, we need to distinguish between inadequate treatment or treatment failure and the occurrence or development of iris. So the treatment options depend on what we think is going on in the setting of an individual patient. If this is an iris syndrome, generally you can treat it, if it's not severe, with anti-inflammatory agents or corticosteroids while you're continuing therapy for cryptococcal meningitis. Most often we will initiate or switch to induction therapy for cryptococcal meningitis, even in the absence of positive cultures, if we're going to use corticosteroid therapy. So we may switch to or restart amphotericin B and flucytosine, or to higher doses of fluconazole when we suspect treatment failure. The echinocandins, another type of antifungal therapy, are not active against cryptococcal disease and therefore can't be used in the setting of treatment failure. But third and fourth generation azole drugs do have activity and may be available in a compassionate use scenario for treatment failure in the context of cryptococcal disease. These include posaconazole and voriconazole. They're very active against cryptococcal species in the laboratory and may have a role in salvage therapy if you can access these drugs. So the next point I'm going to go on to in discussing cryptococcal meningitis is when to start antiretroviral therapy. And as I alluded to in the case presentation, issues related to cryptococcal iris can complicate management and is seen in the setting of earlier initiation of antiretroviral therapy. There have been a number of clinical trials that have looked at early initiation of antiretroviral therapy during an acute opportunistic infection in patients with HIV. The first one really to be published as a randomized clinical trial in which patients were randomized to receive early antiretroviral therapy within the first 2 weeks of opportunistic infection treatment, or randomized to delay therapy until greater than 8 weeks or during consolidation treatment, were enrolled in this study. They were stratified by the particular opportunistic infection and CD4 count at entry. The parent trial itself enrolled individuals who had many different types of opportunistic infections, but included in this trial were 34 patients who also presented with cryptococcal meningitis, about 12% of the patient population. And in the context of the study that was done primarily in settings in the United States, we demonstrated that the risk of mortality was reduced by about 50% when patients received early antiretroviral therapy during the acute treatment for their cryptococcal meningitis, pneumocystis, or serious bacterial infections. So the standard of care in the US had been to initiate antiretroviral therapy within the first 2 weeks of cryptococcal disease. However, this became a controversial issue when data began to emerge from resource-constrained settings. And this was one of the earlier clinical trials that also attempted to look at this question of early versus deferred antiretroviral therapy. And in this case, it was a randomized clinical trial conducted in Zimbabwe. They enrolled 54 patients with a first episode of cryptococcal meningitis. These were all ART naive patients, and because they were being treated in resource-constrained setting of Zimbabwe, they did not have access to amphotericin B or flucytosine, so their standard initiating therapy for cryptococcal meningitis was with high-dose oral fluconazole. And in this case, all patients were managed with 800 milligrams per day. No combination antifungal therapy was used in this study. Patients were then randomized to start antiretroviral therapy within the first 72 hours of their cryptococcal meningitis diagnosis, or to delay antiretroviral therapy for 10 weeks or till completion of the consolidation phase of cryptococcal meningitis treatment. All patients received what was the standard of care regimen for first-line ART at the time this study was done, and in that situation it was a combination of nevirapine, lamivudine, and stavudine, a regimen that we no longer use in most settings. And the median CD4 count at entry into this study was 37 cells. So these were all patients with serious cryptococcal disease, advanced immunosuppression, and what people would consider today to be receiving suboptimal therapy for their cryptococcal meningitis and probably suboptimal antiretroviral therapy. So the findings from this trial need to be taken considered within the context of those issues. But be that as it may, patients who had early initiation of antiretroviral therapy actually had a much higher mortality than patients who had therapy deferred until they completed consolidation phase for their cryptococcal meningitis. There were 23 deaths in the early ART arm compared with 9 deaths in individuals who deferred therapy until completion of consolidation treatment. The median survival in the early group was only 35 days, and in the delayed ART group was 274 days. So this was a small study that really confused the field, I think, in terms of the management of antiretroviral therapy in the setting of cryptococcal meningitis. Many people criticized the outcome of the study because of the suboptimal treatment for cryptococcal meningitis, and there weren't enough data collected in the study to understand whether patients in that early therapy arm had more episodes of iris or paradoxical iris, and there was no management of increased intracranial pressure in this study either. So it wasn't really very easy to tease out some of the factors that were associated with the early deaths seen in this study. So the field was in a bit of a conundrum about one trial showing benefit to early initiation of antiretroviral therapy, although that was mostly done in the setting of developed countries where we had access to amphotericin B and flucytosine for cryptococcal meningitis treatment, and an alternative trial with opposite findings in a setting with suboptimal antiretroviral therapy and suboptimal cryptococcal meningitis treatment. So another trial was undertaken, now referred to as the COAT trial. This was a study done in Uganda and South Africa, And in this randomized controlled trial, 177 HIV-infected individuals who had been hospitalized with a new diagnosis of cryptococcal meningitis were enrolled. These two were a cohort of antiretroviral treatment naive individuals. The median CD4 count, I forgot to write it here on the slide, but the median CD4 count in this study was also in the mid 20 to 30 range, so very advanced immunosuppression. And individuals in this trial were randomized to early ART in this setting within the first 2 weeks after their cryptococcal meningitis diagnosis, or deferred antiretroviral therapy, waiting until 5 weeks after diagnosis. They got what is the standard of care in Uganda and South Africa, the combination of amphotericin B with high-dose fluconazole for an induction phase of therapy for 14 days, and then followed by consolidation therapy with the current recommendation of 400 milligrams daily of fluconazole. And in this trial, too, the investigators demonstrated that those individuals who were treated earlier with antiretroviral therapy had an increased mortality rate. 45% of patients in the early treatment arm had died, and 30% in the deferred therapy arm. Now, one thing to keep in mind here is 30 to 45% mortality rate is actually about 3 times the mortality rate that we see in the US with cryptococcal meningitis. So clearly, these patients are not doing as well as what we have been able to achieve with the combination of amphotericin B with flucytosine. So I think even in this setting, the high-dose fluconazole doesn't work as well in combination with amphotericin B as the flucytosine regimen that we use in the US. But be that as it may, recapitulated the findings from the Zimbabwe study that those who got early antiretroviral therapy had a higher mortality rate than those who deferred antiretroviral treatment until they had better control of their fungal infection. In further findings from this study, the excess deaths between the two groups occurred not in the first 2 weeks of treatment, but between the 2 and 5 week period. And after 5 weeks, the mortality rate was actually the same for both groups. And the factors that appeared to be associated with early mortality in this setting were very low CSF white blood cell counts, so people who were not able to mount an inflammatory reaction in the spinal fluid, and this resulted in about a 3 to 4-fold higher mortality rate than individuals who mounted a good inflammatory reaction in the CSF. Other factors, such as adverse events related to the drugs or the occurrence of iris or other outcomes, were similar between the two groups, so didn't appear to play a role in the early mortality rate. So what has emerged based on these two studies done in resource-limited settings has been a change in the guidelines in terms of managing antiretroviral therapy during acute cryptococcal meningitis. In the US, our Department of Health and Human Services guidelines now recommend delaying antiretroviral therapy initiation at least until completion of the induction phase of cryptococcal meningitis, which means greater than 2 weeks, and consider delaying until completion of consolidation therapy. But we have some caveats to this, because studies that have been done in developed countries have not demonstrated this early mortality effect. So I think there's a lot of controversy still in developed countries about whether we really should delay initiation of antiretroviral therapy. But generally, the thought is that you should wait until at least 5 weeks of antifungal treatment before starting antiretroviral therapy in those who have high risk factors for early mortality. And those would be people with increased intracranial pressure and a very low CSF white cell count, because they are at greatest risk for dying from cryptococcal meningitis. The WHO, alternatively, takes the stance that you should really defer antiretroviral therapy until after 4 to 6 weeks of induction and consolidation therapy if all you have access to is high-dose fluconazole treatment for cryptococcal meningitis. So I think these issues are somewhat in evolution as we tease out and have more experience in initiating antiretroviral therapy in the setting of cryptococcal disease. So once you have finished maintenance therapy of fluconazole for more than a year, there should be consideration to discontinuing secondary prophylaxis or maintenance therapy. And as I alluded to earlier, once patients have completed 1 year of maintenance therapy, if they've had a CD4 count increase to at least above 100 cells per microliter and their viral load has been suppressed for at least 3 months on effective antiretroviral therapy, you can safely discontinue maintenance therapy for cryptococcal disease. Most experts would recommend that if patients don't have an increase in their CD4 cell count, or if they fail antiretroviral therapy and have, again, a decline in their CD4 cell count, that they go back on maintenance therapy or secondary prophylaxis with fluconazole in a dose of 200 milligrams per day. So how do you prevent cryptococcal disease from happening? Obviously, in resource-constrained settings, if you have a mortality rate of 30 to 45%, regardless of antiretroviral therapy or good treatment for cryptococcal disease, you'd like to be able to prevent the disease from happening at all. There are a number of studies that have been done in the US looking at prophylactic fluconazole or prophylactic itraconazole in reducing the incidence of cryptococcal disease in people with very low CD4 counts. All of those studies were done before we had effective antiretroviral therapy, and there was no recommendation made to prophylactically use fluconazole or itraconazole because it turned out to have no benefit in terms of reducing mortality. So it may have reduced the incidence of cryptococcal disease, but more importantly, most people feel that it's of primary priority to get patients started on effective antiretroviral therapy so that their CD4 counts go up, rather than trying to initiate prophylactic treatment with another medication that may complicate adherence. So this is primarily driven by the fact that we see infrequent cryptococcal disease, certainly now in the setting of effective antiretroviral therapy, no survival benefit to primary prevention in randomized clinical trials, and the potential for drug resistance, for drug interactions, for increased cost of therapy, and more pills for the patients to take. There was just no recommendation to use primary prophylaxis. However, in resource-constrained settings, again, it's a different story. And we started to see data emerge from some very interesting studies in which patients in Uganda were screened for cryptococcal antigen when they were asymptomatic. And in this particular study, it was a cohort study, not a randomized trial, but investigators in Uganda evaluated 295 patients who had no prior episodes of cryptococcal meningitis, who were otherwise without symptoms, but had very low CD4 counts of less than 100 per microliter. And they did cryptococcal antigen screening in the serum. And in this study, they found about a 9% rate in asymptomatic patients with very advanced immunosuppression of a positive serum cryptococcal antigen. The investigators in this cohort study elected to start patients who had a positive serum cryptococcal antigen on what they referred to as preemptive fluconazole therapy in a dose of 200 to 400 milligrams a day. And this was after ruling out cryptococcal meningitis in these individuals. And they started preemptive therapy before starting antiretroviral treatment so that fluconazole would be on board before starting ART in an effort to prevent some of the inflammatory reactions that might be seen. They found that in the setting of preemptive fluconazole treatment, patients who had asymptomatic positive serum cryptococcal antigens developed cryptococcal meningitis in only about 14%, or 3 of the 21 patients, whereas those individuals who did not receive preemptive fluconazole, all 5 of them went on to develop cryptococcal meningitis. And the 30-month survival for those who got preemptive fluconazole therapy was 71%, and all 5 of these patients died within that 30-month period. They did a cost-effectiveness analysis of this cohort study and found that the number needed to test and treat with preemptive fluconazole therapy in order to prevent 1 case of cryptococcal meningitis was only 11 patients. And if you did the 11-patient calculation with the cost of fluconazole of $190, you were basically spending $190 to prevent 1 case of cryptococcal meningitis. To prevent 1 death, you only needed to treat 16 patients, and the total cost of $226. And the cost-effectiveness ratio was quite favorable, saving $21. So $226 is actually much less than the treatment for 1 episode of cryptococcal meningitis. So a very cost-effective primary prevention strategy in this cohort study in Uganda that has a much higher rate of cryptococcal meningitis and much higher mortality than we see in the US. This has resulted in a number of countries implementing cryptococcal antigen screening for any patient they see with a CD4 count of less than 100. It has been implemented in South Africa guidelines and in some other sub-Saharan African countries. And just to illustrate the implementation of standard cryptococcal antigen screening in one setting, and this was a study in Tanzania that was just reported at the CROI conference this past month, individuals, the standard recommendation was to do lab reflex cryptococcal antigen screening. What this means is that when the laboratory would receive a blood specimen for CD4 count testing from an HIV-infected individual, if the CD4 count was under 150 cells per microliter in the laboratory, they would then send serum from their CD4 count test over to do routine cryptococcal antigen screen. And if the cryptococcal antigen screen was positive, they would both telephone the primary provider and electronically convey the report. And so with immediate reflexed cryptococcal antigen screening and immediate notification to the provider, they had rapid screening and rapid implementation of a lumbar puncture for all patients who were cryptococcal antigen positive, and also were able to do, not waiting for cultures, but to do a lateral flow assay on the CSF looking for cryptococcal disease. And patients who were CRAG positive but lateral flow negative got started on preemptive fluconazole therapy and initiated ART, and if they had a positive lateral flow assay, they were started on treatment for cryptococcal meningitis. So a very interesting study. And what they showed, they screened 500 patients, a lot of people. They found 6.4% of those were cryptococcal antigen positive with this just laboratory reflex screening. And about 12 to 15% were inpatients already, meaning they were hospitalized for some other reason, but 5 to 6% were asymptomatic outpatients. They were able to do an immediate lumbar puncture on 97% of these individuals and found a positive CSF cryptococcal antigen in 39%, and positive lateral flow in 39%. So basically what they were able to demonstrate was an immediate diagnosis of cryptococcal meningitis early in 39% of these individuals that were CRAG positive, and the remainder were started on preemptive fluconazole therapy and got started on that within 1 day of this laboratory reflex screening. And what they were able to demonstrate here, and this is a Kaplan-Meier curve for survival in asymptomatic cryptococcal antigen positive patients, and basically showing that there was no difference in survival at 6 months of follow-up in patients who were asymptomatic, CRAG positive, and got preemptive fluconazole therapy versus those who were negative for cryptococcal antigen. So, and the assumption being that they prevented a significant number of these individuals from going on to develop cryptococcal meningitis. However, among the patients that they did diagnose rapidly with cryptococcal antigen positive and lateral flow positive CSF, the Kaplan-Meier survival deaths, meaning these individuals had cryptococcal meningitis, and this shows their mortality rate. And as you can see, at 6 months of therapy, only 40% of those individuals were still alive. So the conclusion from this study is that laboratory reflex cryptococcal antigen screening picked up a lot of people with asymptomatic cryptococcal antigenemia, and by initiating preemptive fluconazole therapy in addition to antiretroviral therapy, they were able to prevent mortality in a substantial number of individuals. And so I think that's a very interesting study. So in summary, cryptococcal disease is a serious and common opportunistic infection in individuals who are not on antiretroviral therapy and have very low CD4 counts of less than 100. Rapid diagnosis and aggressive initiation of antifungal therapy for those who have active cryptococcal meningitis, and preemptive antifungal therapy for those who are screened for cryptococcal antigen has a significant improvement in overall survival. When to start antiretroviral therapy remains a complicated decision, but in those individuals who have the worst prognostic factors, meaning high intracranial pressures, a lot of cryptococcal disease in the CSF, and low white cell counts in the CSF, delaying antiretroviral therapy for up to 5 weeks after diagnosis is also associated with an improvement in mortality. And obviously, strategies for prevention will depend on your geographic locale and access to effective therapies. In settings like the US, where we have a low rate of cryptococcal disease and a low rate of mortality with effective treatment of cryptococcal disease, it's not cost effective to do cryptococcal antigen screening and preemptive fluconazole therapy. But in resource constrained settings where you don't have access to effective therapies, it's an important adjunct to do cryptococcal antigen screening and preemptive fluconazole therapy for positive cryptococcal antigen in individuals who have low CD4 cell counts. So I'll stop there and take questions.